After 60, these 5 pills increase the risk of heart attack and stroke. There is a profound, often imperceptible physiological transformation that unfolds within the human body after the age of 60. A subtle yet significant shift that most individuals never truly recognize. Medications, once tolerated without a single concern for years, even decades, can gradually begin to manifest entirely different effects. This isn't because the pharmaceutical composition of the pill has altered. Rather, it is a direct consequence of the intricate biological machinery within our own bodies undergoing age-related changes. In some instances, this subtle divergence in response can carry monumental implications, marking the critical distinction between sustained protection and elevated risk, between enduring physiological stability and a gradual, almost imperceptible accumulation of factors leading to profoundly serious cardiovascular events like a debilitating heart attack or a life-altering stroke. What renders this phenomenon particularly perilous is its initially silent nature. There are no immediate red flags, no acute pain signals, no overt symptoms broadcasting a clear warning. It is merely a quiet, insidious shift, unfolding deep within the body's systems, unseen and unfelt until a critical point is reached. Today, our focus will be on unveiling 5 distinct categories of medications that, specifically after the age of 60, have been demonstrably linked to a heightened risk of adverse cardiovascular outcomes. This risk is particularly pronounced when certain pre-existing conditions are present, or, crucially, when these medications continue to be administered and consumed in precisely the same manner as they were in earlier stages of life. It is paramount to underscore that the purpose of this discussion is not to instill fear or anxiety. Instead, it is rooted in a desire for profound understanding, an informed comprehension of the intricate processes unfolding within your body. Such knowledge empowers you to proactively engage in more judicious decision-making regarding your health moving forward. My name is Dr. William, a practicing medical doctor and physician dedicated to the clear and practical elucidation of complex health topics. Through this platform, I aim to demystify the inner workings of the human body and highlight what genuinely contributes to long-term well-being. Should you find this exploration valuable, I encourage you to consider subscribing, but more importantly, I urge you to remain engaged throughout this detailed discussion. The insights we are about to delve into are critical, especially considering that one of the medications we will examine is consumed daily by millions globally, often without a moment's questioning or reevaluation. To truly grasp why these inherent risks associated with medication use escalate significantly after 60, one must first confront a fundamental biological truth, often overlooked or left untold. Your body's capacity to process and respond to medications is not static. It undergoes profound changes with age. This is the pivotal juncture where the paradigm shifts and the context of medication efficacy and safety begins to fundamentally transform. As we journey through the aging process, several vital physiological systems within the body experience a gradual but definite deceleration. The liver, a metabolic powerhouse primarily responsible for the intricate breakdown and detoxification of countless medications, progressively becomes less efficient in its enzymatic functions. Concurrently, kidneys, the body's sophisticated filtration system tasked with eliminating waste products and excess substances from the bloodstream, also experience a decline in their overall filtering capacity. The profound implication of this dual slowdown is that pharmaceutical compounds remain circulating within your system for extended durations, sometimes considerably longer than initially anticipated or intended. When this prolonged systemic presence occurs, even a previously standard or seemingly normal dosage can begin to exert effects akin to a substantially higher dose over time, placing undue stress on various organs and systems. However, This altered drug metabolism represents only a fraction of the larger narrative. There is an equally critical shift in the intrinsic responsiveness of your cardiovascular system. Arteries, which once boasted remarkable elasticity, gradually become stiffer and less flexible. The delicate inner lining of your blood vessels, known as the endothelium, becomes more sensitive to various stressors. Circulation patterns themselves undergo subtle alterations, and the finely tuned balance between the body's clotting and bleeding mechanisms becomes significantly more delicate and prone to disruption. Consequently, when a medication interacts with any of these age-modified systems, its physiological effects can be disproportionately amplified, leading to unforeseen consequences. This is precisely where widespread misunderstanding often arises. The medication itself is not inherently dangerous. Indeed, it may have been an entirely appropriate and beneficial intervention when it was initially prescribed. It may even retain some therapeutic utility in the present. The crucial distinction lies in the altered biological context. Medicine, more than most realize, is inextricably linked to context. The identical drug at the same dosage can be a potent therapeutic ally in one specific clinical scenario, yet a significant source of risk in another. A dosage perfectly appropriate for a 50-year-old may prove dangerously excessive for a 70-year-old. Yet in the practical realities of everyday healthcare, countless prescriptions are continued for many years without comprehensive, detailed reevaluation. This is rarely a reflection of medical indifference. Rather, these profound physiological changes occur gradually, subtly, almost imperceptibly, operating silently in the background of our daily lives. This brings us to a more serious dimension of the issue. After 60, the intrinsic, natural risk of major cardiovascular events like heart attacks and strokes inherently escalates. This constitutes a well-established baseline risk. However, when certain medications are introduced or maintained without appropriate adjustment atop this elevated baseline, they possess the capacity to significantly amplify that risk. This augmentation can sometimes be subtle, a slow simmer beneath the surface, but at other times it can be dramatically significant, often unfolding without any discernible symptoms until a critical event manifests. This is precisely why today's discussion holds such vital importance. We are not merely discussing abstract pharmaceutical compounds, but rather the dynamic, ongoing interaction between your evolving body and these medications, specifically at this pivotal stage of life. More critically, we are exploring actionable steps you can take to proactively manage this complex interplay. Before we delve into the first two specific medications, it is imperative to establish a foundational principle. Absolutely none of the information we are about to discuss should be interpreted as a directive to independently cease taking any prescribed medication. That is fundamentally not the objective here. The overarching goal is to foster informed awareness. When you possess a deeper understanding of how something functions and interacts with your unique physiology, you are empowered to formulate more insightful questions, engage in more informed dialogues with your healthcare providers, and ultimately avoid the perilous pitfall of operating on autopilot with treatments that may critically require adjustment. This awareness marks the genesis of a crucial layer of self-protection. The initial two medications we will explore are among the most ubiquitously utilized, particularly within the demographic aged 60 and above. They are frequently taken on a daily basis, widely perceived as unequivocally safe, and yet, under specific conditions inherent to an aging body, they possess the silent capacity to increase strain on the heart, subtly alter blood pressure in an adverse direction, or compromise optimal blood flow through already sensitive and less elastic vascular pathways. Once you grasp the insidious mechanisms by which these effects unfold, you will begin to understand that the implications extend far beyond the pill itself. It becomes a complex interplay of timing, precise dosage, and the profound physiological changes your body has undergone. This realization is precisely where our journey of understanding continues. Let us commence our exploration with a medication category that is astonishingly common, often consumed for years, even decades, without a second thought by countless individuals. Yet, after the age of 60, its behavior within the intricate systems of the body begins to diverge dramatically. The first category comprises a widely used group of drugs known as non-steroidal anti-inflammatory drugs, or NSAIDs. This extensive class encompasses familiar over-the-counter mainstays like ibuprofen and naproxen, as well as several prescription-strength anti-inflammatory compounds. NSAIDs are routinely employed for a vast array of ailments, including chronic joint pain, persistent back pain, the pervasive discomfort of arthritis, and general everyday inflammation. For a substantial number of people, they present as a deceptively simple and effective solution. Take a pill, the pain subsides, and life resumes its normal course. However, beneath this immediate sensation of relief, a more complex and potentially detrimental process is unfolding within the body's delicate biochemical landscape. NSAIDs exert their therapeutic effect by inhibiting specific enzymes, primarily cyclooxygenase, COX-1 and COX-2, which are intricately involved in the synthesis of prostaglandins, signaling molecules that mediate inflammation and pain. While this enzyme inhibition effectively reduces pain and inflammation, these very same enzymes also play a vital protective role in maintaining the integrity and optimal function of your blood vessels and regulating proper blood flow. Herein lies the critical nexus of the issue. After the age of 60, your blood vessels are already inherently less flexible, having undergone structural changes over time. The delicate inner lining of your arteries, the endothelium, becomes markedly more susceptible to stress and damage. When NSAIDs intervene by interfering with the protective functions mediated by these enzymes, it can precipitate a subtle yet significant tightening or constriction of the blood vessels. This vasoconstriction invariably leads to an elevation in blood pressure, a rise that is not always immediately palpable or consciously noticed. It can be a gradual, quiet, but relentlessly persistent upward creep. Simultaneously, NSAIDs exert an influence on the kidney's crucial role in regulating fluid and electrolyte balance. They can induce the body to retain an increased amount of sodium and, consequently, water. This fluid retention, in turn, imposes an additional, measurable strain on the heart, forcing it to work harder to circulate a greater volume of blood. Thus, two compounding factors emerge concurrently: increased systemic blood pressure and an elevated fluid load. For an individual whose cardiovascular system is already performing under a greater workload after the age of 60 due to natural aging processes, this insidious combination of effects carries profound implications for long-term cardiac health. Numerous large-scale epidemiological and clinical studies have consistently demonstrated a robust association between the long-term or frequent use of NSAIDs and a statistically significant increased risk of heart attack and stroke, particularly among older adults or those with pre-existing cardiovascular risk factors. The deceptive element here is the immediate relief versus the slow, cumulative impact. One does not consciously perceive their blood pressure incrementally rising in real time, nor does one feel the added daily strain on their arteries. Yet, over extended periods, these subtle physiological stressors inexorably accumulate. It is imperative to clarify that this does not unequivocally brand NSAIDs as inherently bad medications. Rather, it emphasizes the critical necessity for their use to be governed by informed awareness and judicious clinical oversight. Short-term, occasional, or meticulously monitored use may very well remain appropriate and beneficial. However, the unchecked, daily, long-term use of NSAIDs without rigorous reevaluation after the age of 60 is precisely where the cardiovascular risks begin to escalate significantly. This detailed examination naturally leads us to the second medication category, one that is arguably even more subtle in its effects and frequently more underestimated in its potential ramifications. This class of drugs is known as proton pump inhibitors, commonly abbreviated as PPIs. This category encompasses widely recognized medications such as omeprazole, esomeprazole, lansoprazole, and other similar powerful acid-reducing compounds. PPIs are routinely prescribed for a spectrum of gastrointestinal conditions, including symptomatic acid reflux, persistent heartburn, and, crucially, for the prophylactic protection of the stomach lining, particularly in individuals concurrently taking other medications known to irritate the gastrointestinal tract. On the surface, their mechanism of action appears benign and their benefits clear. They effectively reduce stomach acid production, alleviate discomfort, and protect the delicate gastric mucosa. Yet, beneath this seemingly straightforward therapeutic profile, a more nuanced and less obvious set of consequences begins to unfold. Stomach acid, often viewed solely as a source of discomfort, plays a multifaceted and essential role in the intricate process of digestion and, critically, in the absorption of key micronutrients from our diet. Among these vital nutrients are magnesium, calcium, and vitamin B12. Over time, the chronic, long-term use of PPIs can significantly impair the absorption of these essential nutrients. While this might not immediately strike one as directly correlating with the risk of heart attack or stroke, the connection is profound and undeniable. Magnesium, for instance, is an indispensable electrolyte that plays a critical role in maintaining stable heart rhythms and supporting overall cardiac muscle function. Chronically low magnesium levels, a potential consequence of prolonged PPI use, can significantly elevate the risk of developing irregular and potentially dangerous heart rhythms known as arrhythmias. Calcium, though often associated primarily with bone health, is also intricately involved in vascular function, influencing the contraction and relaxation of blood vessels. Disturbances in calcium balance can therefore indirectly affect cardiovascular dynamics. Furthermore, vitamin B12 is essential for a myriad of bodily functions, including the production of red blood cells and the maintenance of healthy nerve function. Critically, it is also indirectly involved in maintaining the health and integrity of blood vessels. When the optimal levels of these vital nutrients are disrupted over extended periods due to impaired absorption, the cardiovascular system, already inherently more vulnerable in an aging individual, becomes further predisposed to dysfunction and increased risk. Beyond nutrient malabsorption, there is an additional layer of concern. A growing body of research has put forth compelling suggestions that long-term use of PPIs may directly impact the delicate function of the endothelium, the crucial inner lining of all blood vessels. This endothelial layer is not merely a passive barrier. It is an active, dynamic tissue essential for the precise control of blood flow, the regulation of clotting processes, and the vital relaxation of blood vessels. When the endothelium ceases to function optimally due to potential PPI-induced effects, the risk of various vascular events, including those leading to heart attack and stroke, becomes elevated. Once again, it is crucial to emphasize that these subtle, cumulative changes do not manifest overnight in a dramatic fashion. They evolve slowly, silently, often without any clear or alarming symptoms, making them particularly insidious. A common scenario involves individuals being initially prescribed a PPI for a relatively short-term issue, such as an acute episode of acid reflux or temporary stomach irritation. However, due to its efficacy and perceived safety, they then continue taking it for years, even decades, without any subsequent medical reassessment. This protracted, unreviewed usage persists because the medication feels safe, because it was initially prescribed, and because nothing seems wrong. Yet, the longer this continuous use persists without critical review, the more the subtle, underlying physiological effects begin to accumulate and matter, quietly increasing vulnerability. This is precisely where informed awareness becomes a game changer. The optimal solution is not always the abrupt cessation of the medication. Instead, it might involve a judicious adjustment of the duration of treatment, a thorough reassessment of the ongoing need for the drug, or an exploration of whether a lower dose or an entirely alternative therapeutic approach might be more appropriate and safer. However, such crucial reevaluations and adjustments only materialize when the fundamental question of ongoing necessity is actually raised by either the patient or the healthcare provider. What we have meticulously covered thus far represents just the initial layer of understanding: two exceptionally common medications, each operating through distinct mechanisms, yet both capable of quietly amplifying cardiovascular strain over extended periods in the aging body. However, the subsequent discussions will delve into even deeper, more complex interactions. The next two categories of medications do not merely affect blood pressure or nutrient levels. They engage in direct and profound interactions with how your heart fundamentally functions, how your blood circulates, and how your entire physiological system responds under conditions of stress. Once these intricate relationships are clearly understood, the comprehensive picture of cardiovascular risk in older adults becomes far more lucid and actionable. This is the juncture where the discussion transitions from subtle influences to factors that can carry significantly more potent implications. The subsequent two medication classes do not merely modulate blood pressure or influence micronutrient status. They interact directly and substantially with the intricate ways your cardiovascular system responds, particularly when confronted with stress. In a multitude of cases, the adverse effects are not immediately evident. Rather, they accumulate gradually over many months, sometimes even years. This protracted and insidious buildup is precisely why these risks are so frequently overlooked or misattributed. Let us now turn our attention to the third medication category, a class of pharmaceutical agents widely utilized for inducing sleep, mitigating anxiety, or generally calming the central nervous system. These are collectively known as benzodiazepines. Prominent examples within this class include diazepam, lorazepam, alprazolam, and other structurally similar compounds. Their efficacy is undeniable. They possess the capacity to rapidly alleviate acute anxiety and are frequently effective aids for sleep induction. For many individuals, particularly as they advance in age, these medications can feel like an indispensable support, providing relief from distressing symptoms. However, it is crucial to examine the underlying physiological events. Benzodiazepines exert their primary effects by enhancing the activity of gamma-aminobutyric acid, GABA, the brain's principal inhibitory neurotransmitter. This mechanism effectively slows down brain activity, thereby producing the desired calming and sedative effects. Yet, this broad central nervous system depression is not confined solely to brain function. It concurrently decelerates other critical bodily systems, including respiratory drive, leading to shallower breathing, reaction time, and overall motor coordination. The pertinent question then arises: how does this complex neurophysiological interaction directly correlate with an elevated risk of heart attack or stroke? This is where understanding the intricate mechanism of action becomes paramount, especially in the context of an aging physiology. As individuals age, the body's sensitivity to benzodiazepines increases markedly. The metabolic pathways responsible for their breakdown and elimination become less efficient, leading to a prolonged systemic presence. These drugs accumulate more readily within the body, and their inherent sedative effects are consequently amplified, often even when the dosage remains unchanged. Over time, the pervasive sedative effects can translate into a significant reduction in overall physical activity, diminished spontaneous movement, and an increased duration spent in sedentary postures, such as sitting or lying down. This seemingly innocuous behavioral shift carries far greater implications than most people realize, particularly for cardiovascular health. Optimal blood circulation is fundamentally dependent on regular physical movement, which facilitates venous return and lymphatic drainage. When physical activity substantially decreases, blood flow becomes less efficient, leading to sluggish circulation. This reduction in circulatory dynamics, in turn, elevates the risk of venous clot formation, example, deep vein thrombosis, and compromises the efficient delivery of oxygen to vital tissues throughout the body. Furthermore, there is an additional critical layer of risk. Benzodiazepines can significantly interfere with normal breathing patterns, particularly during sleep. They can exacerbate pre-existing sleep-related breathing disorders, such as obstructive sleep apnea, or induce shallow breathing patterns even in individuals without prior diagnoses. When oxygen saturation levels drop repeatedly throughout the night, even if subtly, it imposes chronic and cumulative additional strain on the heart, which must work harder to compensate for periods of hypoxia. Thus, a dangerous confluence of factors emerges. Compromised circulation due to diminished physical activity, recurrent episodes of lower oxygen levels, and an already intrinsically vulnerable aging cardiovascular system. Again, these manifestations rarely feel dramatic. They are often perceived simply as increased fatigue, a sense of sluggishness in the mornings, or merely normal aging. Yet, beneath this veneer of normalcy, the entire cardiovascular system is operating under significantly greater stress than it should be. Over time, these seemingly minor physiological shifts can collectively contribute to a substantially higher long-term risk of adverse cardiovascular events, especially when compounded by other prevalent risk factors like uncontrolled hypertension or pre-existing vascular disease. It is a critical insight, often missed, that the risk emanates not solely from the act of taking the medication, but from its continuous, unreviewed administration as the body inexorably changes with age. This segues seamlessly into the fourth medication category, which introduces an even greater degree of complexity. This intricacy arises not primarily from the drug's isolated action, but from its intricate and often perilous interactions with a multitude of other physiological processes and co-administered medications. The fourth category encompasses certain decongestants and various stimulant-like compounds. This includes over-the-counter and prescription medications containing active ingredients such as pseudoephedrine and phenylephrine, frequently found in combination cold and allergy remedies. These drugs are ubiquitously used for alleviating symptoms of sinus congestion, common colds, or seasonal allergic discomfort. Their widespread availability over the counter often imbues them with a false sense of absolute safety. However, their underlying mechanism of action is fundamentally distinct and carries significant cardiovascular implications. Decongestants primarily exert their effect by inducing vasoconstriction, the narrowing of blood vessels. This localized constriction in the nasal passages effectively reduces swelling and facilitates easier breathing. Crucially, however, this vasoconstrictive effect is not confined solely to the nasal vasculature. It extends systemically, impacting blood vessels throughout the entire body, including those intimately connected to and surrounding the heart. When widespread blood vessel constriction occurs, systemic blood pressure inevitably rises, the heart rate can increase, and the heart muscle is compelled to exert greater effort to propel blood through a more restricted, tighter circulatory system. In a younger, physiologically resilient body possessing flexible and responsive arteries, this temporary effect is generally well tolerated and transient. However, after the age of 60, when arteries have already lost a significant degree of their inherent elasticity and become stiffer, this added systemic constriction can become profoundly significant and dangerous. This risk is particularly acute if an individual already suffers from pre-existing hypertension, high blood pressure, or is concurrently taking other medications that influence cardiovascular function. This scenario highlights the perilous potential of polypharmacy and drug-drug interactions. It is a common reality that many older adults do not take just a single medication. Rather, they manage a complex regimen involving several pharmaceutical agents. Imagine an individual taking a medication for blood pressure control, a pain reliever for chronic discomfort, something to aid sleep, and then, during a cold or allergy season, adds a potent decongestant to this already complex regimen. Individually, each medication might seem manageable and relatively innocuous. However, taken together, these compounds initiate a complex cascade of interactions. One agent elevates blood pressure, another alters fluid balance, a third dampens overall systemic function, and the body's already challenged homeostatic mechanisms are forced into continuous compensatory overdrive. This is where individuals are often caught entirely off guard. The precipitating event, the heart attack or stroke, often appears to manifest abruptly, seemingly out of nowhere. Yet, the underlying physiological buildup of stress and vulnerability on the cardiovascular system has been occurring insidiously for a prolonged period. This gradual, silent accumulation is what renders these situations so misleading and dangerous. The sudden event feels entirely unexpected, but in truth, it represents the culmination of a chronic, incremental burden on the heart and blood vessels. This profound awareness of cumulative effects and interactions is therefore paramount. When one understands how these various medications interact within the unique context of an aging body, patterns of vulnerability become discernible, allowing for the proactive recognition of when a therapeutic strategy may no longer be operating in one's best interest. This leads us to the final critical medication, which is often the most surprising to many. This final medication stands out not due to its rarity, but precisely because of its ubiquitous presence, its incredibly widespread use, and the almost universal trust it commands, rarely subjected to scrutiny. Once its nuanced interaction with the aging body after 60 is fully comprehended, it fundamentally alters one's perspective on its appropriate application. This is arguably the medication that most consistently elicits surprise. Not because it is obscure or infrequently employed, but because it is quite literally everywhere, taken daily by millions, widely trusted, and generally presumed to be entirely benign. Yet, specifically after the age of 60, its interaction with your body can subtly, but dangerously, shift in a direction that elevates cardiovascular risk, particularly when its use is not subjected to regular, informed medical review. The fifth medication is low-dose aspirin. For many years, aspirin was broadly championed and widely recommended as a simple, accessible means of cardiovascular protection. A small daily dose, often referred to as baby aspirin, was widely believed to aid in the prevention of heart attacks and strokes by inhibiting blood clot formation. And in certain specific clinical scenarios, this protective role remains entirely valid and crucial. For individuals who have already experienced a prior heart attack or stroke, or who possess unequivocally high-risk conditions such as established peripheral artery disease, aspirin can indeed play an indispensable and important protective role as part of a secondary prevention strategy. However, the medical landscape, informed by evolving research, has undergone a significant paradigm shift. More recent, large-scale clinical trials and comprehensive meta-analyses have revealed that for a substantial proportion of healthy adults over the age of 60 who have not previously experienced a cardiovascular event, i.e., for primary prevention, the routine daily use of aspirin may not confer the broad protective benefits once universally assumed. In fact, in certain demographic segments, its routine use may actually demonstrably increase overall risk. Let us meticulously deconstruct the underlying reasons for this reevaluation. Aspirin works by irreversibly inhibiting cyclooxygenase enzymes, primarily COX-1, in platelets, thereby reducing their ability to aggregate or stick together. This antiplatelet action is precisely what helps to prevent the formation of pathological clots within arteries, which can lead to ischemic events. However, the body's ability to form clots is not solely a harmful mechanism. It is also a vital, intrinsic protective mechanism. It is how your body staunchly stops bleeding when blood vessels are physically damaged or injured. After the age of 60, blood vessels generally become more fragile and susceptible to injury. Concurrently, the delicate lining of the digestive tract, particularly the stomach and intestines, also becomes more sensitive and prone to erosion or bleeding. Furthermore, the finely calibrated balance between the body's sophisticated clotting mechanisms and its equally vital bleeding control systems becomes inherently more delicate and easily perturbed. Consequently, when aspirin profoundly reduces the body's clotting ability within this altered physiological context, it can significantly elevate the risk of spontaneous internal bleeding, most notably in the gastrointestinal tract, leading to ulcers or hemorrhages, or, more gravely, within the delicate structures of the brain, intracranial hemorrhage. One might then reasonably inquire, how does this heightened bleeding risk specifically connect to the overall risk of stroke or heart attack? This is where nuanced understanding is absolutely paramount. There are two primary classifications of stroke. One type, an ischemic stroke, is caused by a blood clot obstructing blood flow to a region of the brain. The other type, a hemorrhagic stroke, is caused by bleeding directly into the brain tissue. While aspirin can effectively reduce the risk of clot-related ischemic strokes, its mechanism simultaneously increases the risk of bleeding-related hemorrhagic strokes. After the age of 60, particularly in individuals without a clear, established history of cardiovascular disease, that delicate risk-benefit balance can critically shift. In a significant number of individuals, the increased risk of potentially severe bleeding begins to statistically outweigh any perceived or actual protective benefit against clotting events. This reevaluation of the risk-benefit profile is precisely what more recent clinical guidelines from major cardiology and preventive health organizations have begun to reflect, advising a much more individualized and cautious approach to aspirin for primary prevention in older adults. Herein lies an even more crucial point. Countless individuals initiated daily low-dose aspirin therapy years ago, based on older recommendations, and have simply continued the regimen without any subsequent change or medical reassessment. It became an ingrained, seemingly safe preventive habit. However, medical science is a dynamic and evolving field. What constituted standard practice decades ago is not always the optimal or safest approach today. This reevaluation does not imply that aspirin is inherently bad or useless. Rather, it underscores its specificity. Aspirin must be meticulously matched to the appropriate clinical situation, the precise individual risk profile, and the unique characteristics of the individual patient. This is precisely where a profound understanding of your own individual medical context becomes absolutely critical. Taking aspirin merely just in case, without a clear, evidence-based determination of whether it genuinely benefits you specifically, can inadvertently create a scenario where significant bleeding risk is introduced without providing any meaningful, demonstrable cardiovascular protection. This brings us to the profound shift in perspective that truly matters. Up to this juncture, we have meticulously discussed 5 distinct categories of medications, each possessing a unique mechanism of action and affecting the body through different physiological pathways. Yet they all share one overarching critical commonality. Their potential for adverse effects and overall risk escalates significantly when they are continued to be taken in precisely the same unchanging manner, despite the undeniable age-related transformations occurring within the body over time. And it is precisely at this juncture that agency and control rightfully return to you, the individual. Because the single most important, empowering step is not a wholesale cessation of all medications. Rather, it is cultivating an informed understanding of which medications, in your particular context, warrant a thorough and proactive reevaluation. Therefore, here are several practical, actionable steps that can genuinely make a tangible difference in safeguarding your health. Firstly, cultivate a habit of proactively reviewing all your medications on a regular basis. This should not be limited to reactive reviews when a problem or new symptom arises, but rather a consistent, proactive engagement with your healthcare team. During your medical appointments or with your pharmacist, ask very specific, pointed questions. Do I still require this particular medication at this exact dosage given my current age and health status? Has my overall risk profile changed over the years? Are there potentially safer or equally effective alternative approaches available that might be more appropriate for me at this current stage of life? Secondly, develop a keen awareness of medication combinations. Many of the inherent risks we have discussed are not solely attributable to a single medication in isolation, but rather emerge from the complex, often synergistic interactions between multiple drugs. This comprehensive awareness must extend even to seemingly innocuous over-the-counter medications and even sporadic, occasional use. In the intricate tapestry of your body's physiology, every chemical compound counts and contributes to the overall effect. Thirdly, attune yourself to recognizing subtle physiological signals. These are rarely dramatic, acute symptoms. Rather, they manifest as small, often persistent changes in your baseline well-being. This could include an unaccustomed increase in general fatigue, a new or exacerbated shortness of breath during activities that were previously effortless, episodes of unusual dizziness or lightheadedness, or subtle but consistent alterations in your blood pressure readings. These seemingly minor shifts are frequently early, invaluable indicators that something within your physiological system may require adjustment or closer medical attention. Finally, embrace the fundamental understanding that your body is not a static entity. What proved highly effective and ideal 10 years ago may no longer be the optimal approach today. This recognition is not an indictment or a problem. It is simply an inherent, natural part of the dynamic process of human evolution and aging. What we have covered thus far provides you with a clear, comprehensive picture of the potential origins of medication-related risks in later life. However, the most critical dimension of this discussion still lies ahead, because merely understanding the problem represents only one facet of proactive health management. What truly holds profound significance is how you choose to leverage this information moving forward and how you apply it to protect and optimize your health in a manner that is realistic, practical, and deeply grounded in the current, actual workings of your body today. If there is but one singular, overarching principle to distill from everything we have just meticulously explored, it is this: the true underlying risk is not necessarily inherent in the medication itself. Rather, it lies in the continued, unquestioning administration of that medication in precisely the same manner, at the same dosage, while your body has unequivocally undergone significant, fundamental changes and is no longer the same physiological entity it once was. Because after the age of 60, your body is not merely an older iteration of its former self. It functions through altered pathways. It processes exogenous substances with different metabolic efficiencies. It responds to internal and external stressors in distinct ways. And most crucially, its capacity to tolerate imbalances and physiological deviations is markedly diminished. This implies that even seemingly minor mismatches, small excesses in dosage, and subtle drug-drug interactions, which might have been inconsequential in youth, can now exert a disproportionately larger and potentially more detrimental impact. This is precisely the pattern into which many individuals unwittingly fall. They instinctively continue therapeutic regimens that have always worked. They implicitly trust prescriptions that have always been given. They adhere meticulously to the same daily routine year after year without truly apprehending that the underlying physiological context has fundamentally shifted beneath their feet. And it is imperative to reiterate that this is not about individuals actively doing something wrong. It is, more often than not, a consequence of something that was never adequately or clearly explained to them in the first place. Because within the expansive domain of medicine, there exists a profound concept that regrettably receives insufficient attention and emphasis. Not every health challenge necessitates the addition of a new intervention. Equally, and often more importantly, some existing treatments require judicious adjustment, careful reduction, or even complete reconsideration and cessation. This dynamic process of deprescribing and reevaluating is every bit as critical and impactful as the initial decision to commence a treatment in the first place. This understanding, rather than being a source of concern, should be deeply empowering. Once you fully grasp this fundamental principle, your perception of your own health and medical management begins to transform. You cease to view medications as immutable, permanent solutions, and instead, you begin to perceive them as sophisticated tools. Like any tool, they need to be employed at the precise right moment, in the correct manner, and critically, for the appropriate stage of your life. When this alignment between the tool and the current physiological context is accurate and maintained, medications can be extraordinarily helpful and life-enhancing. However, when that vital alignment drifts even subtly, that is precisely where accumulated risk begins its insidious development. Now, reflect upon the 5 medication categories we have diligently discussed. Pain relievers, specifically NSAIDs. While undeniably helpful for effectively reducing inflammation and alleviating discomfort, they harbor the capacity to insidiously increase systemic blood pressure and promote fluid retention, particularly when used chronically and without proper monitoring. Acid-reducing drugs, such as proton pump inhibitors, PPIs. Utterly indispensable for protecting the delicate stomach lining and managing severe acid-related conditions, yet prolonged use can disrupt the critical absorption of vital nutrients and potentially compromise endothelial function over time, subtly affecting vascular health. Benzodiazepines, potent agents for calming the central nervous system and alleviating anxiety, but their sedative effects can significantly reduce physical activity, alter crucial breathing patterns, especially during sleep, and thereby adversely impact overall circulation, increasing cardiovascular strain. Decongestants. highly effective in clearing obstructed sinuses and relieving congestion, but their systemic vasoconstrictive action inherently tightens blood vessels throughout the body, elevating blood pressure and consequently increasing the overall workload and strain on the cardiovascular system. Aspirin, a long-standing guardian against clot formation, truly life-saving in the correct secondary prevention context. However, when its use is not clearly indicated for primary prevention in older adults, it can significantly increase the risk of serious bleeding events, necessitating a careful, individualized risk-benefit analysis. Each of these medications possesses a legitimate therapeutic purpose. Each holds intrinsic value when appropriately prescribed. However, each also possesses a critical threshold, a point at which its risk-benefit balance can fundamentally shift. This pivotal point is not fixed. It dynamically moves and evolves with advancing age, with other concurrent changes in your body, with the addition or subtraction of other medications, with lifestyle choices, and crucially, with the presence and progression of underlying health conditions. This inherent dynamism is precisely why informed awareness, more than any other single factor, holds the greatest significance. Because genuine awareness invariably leads to the formulation of more insightful and pertinent questions, and more insightful questions invariably lead to better, more judicious decisions regarding your health. Here is a simple yet incredibly powerful strategy that you can implement immediately. At your very next medical appointment, instead of solely focusing on reporting new symptoms or discussing potential new prescriptions, intentionally shift the conversation. Ask this profound and empowering question. Is everything I am currently taking still optimally appropriate for me at this specific stage of my life, given my current health profile? That singular question possesses the transformative power to entirely reframe the discussion. It redirects the focus from merely adding interventions to thoughtfully evaluating existing ones, from reactively addressing problems to proactively optimizing your current regimen. And often, this question opens the door to crucial adjustments that can significantly reduce potential risks without compromising or removing necessary therapeutic support. Because, to reiterate, the ultimate goal is not a wholesale abandonment of all medications. It is to ensure that every single medication you are currently taking continues to operate squarely in your favor, aligned with your current physiological needs and vulnerabilities. Another immensely important point is to recognize that your body provides constant signals. They are not always overtly loud or dramatic, but they are consistently present. Cultivating the ability to notice and interpret these subtle cues can make a profound difference in your health trajectory. Subtle, persistent increases in generalized fatigue, a palpable sense that your energy levels dissipate far more rapidly than they once did. Episodes of lightheadedness or dizziness upon standing, a noticeable shortness of breath during activities that were previously effortless, or inexplicable changes in the quality or duration of your sleep. These manifestations are rarely dramatic or acute, but they are invariably meaningful. They frequently serve as early indicators that something within the complex systems of your body requires attention, adjustment, or medical review. When you consciously combine this heightened bodily awareness with a commitment to regular, proactive medication review with your healthcare team, you cultivate a level of health control and personal agency that a majority of people regrettably never develop. This brings us to the culmination of our discussion, where all these interconnected threads converge. The critical difference between reacting to the devastating aftermath of a heart attack or stroke and proactively preventing such an event often hinges entirely on a series of small, informed adjustments made early in the process. It is rarely about one single monumental change or one dramatic isolated intervention. Instead, it is about a continuous series of well-informed, judicious decisions that consistently work to maintain your physiological systems in a state of optimal balance over extended periods. And it is precisely here that you possess far greater influence and control than you might initially perceive. While you may not possess complete control over every single risk factor that impacts your health, you unequivocally possess control over your level of awareness. You possess the agency to ask probing and pertinent questions, and you certainly possess the control to ensure that your current medication routine remains optimally matched and aligned with the unique and evolving needs of your current body. That is the fundamental differentiator. It is not driven by fear or avoidance, but by a powerful commitment to alignment and informed management. If this comprehensive discussion has helped clarify any aspect of your health or has prompted you to view your current health routine with a fresh, more informed perspective, I sincerely encourage you to remain connected to this channel. Our unwavering focus here is precisely on this, providing not quick fixes or exaggerated claims, but rather a clear, practical, and evidence-based understanding of how the intricate human body truly functions and what genuinely makes a significant, enduring difference to long-term health and well-being. Furthermore, if you know someone who regularly takes medications, particularly if they are over the age of 60, sharing this crucial information with them could genuinely make a profound impact on their life. Because sometimes the most important and transformative changes in health begin with a simple yet powerful realization that what once worked perfectly well may now need to be carefully re-examined, re-evaluated, and potentially adjusted. And once that critical insight is gained, one begins to make health decisions in an entirely new, more informed, and more empowering way.